Hello, I'm Dr. Hafsa, and in this video, I'll be educating you about traumatic brain injuries. Starting off with extradural or epidural hematoma, in which there is bleeding into the space between the dura mater and skull. The dura mater is the outermost layer, whereas the pia mater is the innermost layer. We can remember it as DAP, dura mater being the outermost, pia mater the innermost, and arachnoid in between them. This results due to acceleration and deceleration trauma or blow to the side of the head, specifically pterion, which results in the rupture of the middle meningeal artery, as shown over here. It can also result in the rupture of anterior ethmoidal arteries if trauma is to the frontal region. The patient presents with altered state of consciousness or a lucid state. This is a brief interval where there is regained or restored consciousness. The patient might have CSF leak from the nose, rhinorrhea, or from the ears, otorrhea. The patient might have signs of raised intracranial pressure, for example, nausea, vomiting, or he will have Cushing's reflex, which is a triad of hypertension, bradycardia, or an irregular breathing. Complications may arise if the extradural hematoma is not treated timely. Let's learn this with the help of a diagram. For instance, this is the tentorium, which is the fold of dura mater that separates the cerebellum from cerebrum. And if the complications arise above the tentorium, they compress the arteries leading to ischemic stroke. But if it's below the tentorium, they compress the brain leading to heart and respiratory arrest. To diagnose an epidural hematoma, we generally use a CT scan, which shows a biconvex, heterogeneous and high-density mass, which is generally bright in color. Whereas on the MRI, on the T2 weightage image, we find a hypointense or a dark-colored blood clot. We can also find a swirl sign on the CT scan. This is basically an area of low attenuation within an hyperattenuating hematoma. For instance, this is the hematoma, and this inside is the area of low attenuation or low density, which is darker in color as compared to the rest of the hematoma. Coming on to the management, we use osmotic diuretics like mannitol to decrease the intracranial pressure, and we also go for anticoagulation reversal. But if this does not resolve the problem, craniotomy and hematoma evacuation is eventually needed. Subdural hematoma occurs when there is bleeding into the outermost meningeal layer, that is between the dura mater and the arachnoid mater. This occurs when there is bleeding from the damaged bridging veins in between the cortex and the venous sinuses. The initial injury may be minor and it is often forgotten. It occurs due to trauma, acceleration, deceleration, or coup-countrecoup injuries. The risk factors include old age, alcoholism, and anticoagulation. The patient may present with either loss or altered consciousness. There is sudden and severe headache with nausea and vomiting. There can be unequal pupils, difficulty in speech and swallowing. If this is not treated timely, complications can develop, for example, subdural hygroma, which is liquefaction of the granulation tissue, which mostly occurs in chronic subdural hematoma. This in turn leads to raised protein, which causes expansion of the mass due to water that is drawn by osmotic pressure. Now this leads to mass effect brain injuries. It can also lead to raised ICP, that is intracranial pressure, and progressive dementia. A subdural hematoma on a CT scan appears as a hyperdense, crescent-shaped mass that looks like a moon. Here we can also see shift of the midline, which shows mass effect. On MRI T2 weightage image, we can find a hypointense blood clot. Coming on to the management, we can prescribe diuretics which decrease the intracranial pressure. We give vitamin K, factor VIII inhibitor activity bypassing agent, and fresh frozen plasma. We also reverse the anticoagulation. We can go for a per hole drainage, craniotomy or a decompressive type of PIT, and blood vessel ligation if the diuretics and the above measures fail. Subarachnoid hemorrhage occurs when there is bleeding into the space between the pia mater and the arachnoid membrane, as shown over here. This occurs when there is rupture of the perianeurysms mostly. Perianeurysms are associated with multiple conditions like adult polycystic kidney disease, Ehlers-Danlos syndrome, and coarctation of aorta. It can also occur due to arteriovenous malformations, traumas, or tumors. The patient presents with worst headache of his life, or a thunderclap headache. He can also have altered consciousness, signs of meningeal irritation like neck pain and stiffness. There can also be positive Kernick sign and focal neurological signs, which involve posterior communicating artery and abducens nerve. If this is not treated timely, complications can occur like rebleeding, which occurs mostly in patients with hypertension, anxiety, and seizures. The patient can also develop obstructive hydrocaph due to blood in the ventricles and vasospasm, leading to cerebral ischemia. CT scan of a patient with subarachnoid hemorrhage shows blood in the basal cisterns at the base of the brain, where the circle of Willis is located, as shown over here. The circle of Willis somewhat lies over here, and this star-shaped area shows that the blood has accumulated in the basal cisterns that are folds or compartments of subarachnoid space, which have a lot of CSF in them. The lumbar puncture is done after 12 hours, which gives time for xanthochromia to develop, which is yellow discoloration due to erythrocyte breakage. But if there is no xanthochromia and still there is high clinical suspicion that the patient has subarachnoid hemorrhage, a CTA or cerebral angiography is done. The management involves several steps. The patient is given antihypertensives, osmotic or loop diuretics, calcium channel blockers like nimodipine decrease the vasospasm, and seizures are treated. Endovascular coiling with aneurysm obliteration or craniotomy with aneurysm neck clipping or coiling is done if the above treatment is insufficient. Thank you for watching. Please subscribe and follow for more videos.